Good day everyone, this is Sir Franz and I'll be starting our lesson on the pharmacology of common thyroid disorders. So to start off, let us review some common and basic foundations of the thyroid gland. Here in the image on the left, you will observe that the thyroid gland is below the thyroid cartilage. And you will observe also that the thyroid gland has two lobes, one on the right and one on the left, and these two lobes are connected by a bridge that we call the thyroid isthmus. Anterior to the thyroid gland is the strap muscles, which will help the patient swallow and also flex his neck forward. Behind the thyroid gland are the organs for respiration. You have the trachea, and also behind it still is the esophagus, which connects the mouth and the stomach. Particularly the neck portion or the cervical portion of the esophagus. On the sides of each lobe of the thyroid gland are the jugular vein and the common carotid. Also there you will find the vagus nerve. Okay? What's special is that behind the thyroid gland, particularly the right and the left lobes of the thyroid gland, you will find the recurrent laryngeal nerve, which controls speech and articulation that is found in the larynx. So whenever there is injury to the thyroid gland and whenever there is cancer, or if the thyroid gland is so large that there is compression of this recurrent laryngeal nerve, the patient will manifest with hoarseness. Okay? The patient, because of this anatomy, if the patient has a very large thyroid gland, if there is a goiter, then the patient will have difficulty swallowing because there is impingement of the esophagus, and if it is large enough, it will compress the trachea and the patient will also have difficulty breathing. Okay, so let's move away from that and look at the right portion of the image. On top, you will see a low power magnification of the thyroid gland. So this is a normal thyroid gland, and you will see that there are many follicles where in the middle you will find colloid. So let's now look at the bottom portion of the right panel, where you will see the pink central collection, which we call the colloid. In the colloid, there are lots of thyroid hormone that are bound by the protein thyroglobulin. So later on, when we discuss the physiology of the thyroid gland, we should be able to understand and recall this image that the follicular cells, which here are shown as the blue dots, these are the active nuclei of the thyroid follicular cells. The follicular cells continuously secrete thyroid hormone into the middle, into the colloid. And if the body needs thyroid hormone, then the colloid will be reabsorbed by these follicular cells, and the thyroid hormone is processed and secreted posteriorly, basolaterally into the circulation. So again, the thyroid hormone is in the colloid, and whenever the body needs the hormone, the thyroid follicular cell will eat up this colloid and secrete it into the blood to release the thyroid hormone. here you will see the central regulation of the release of thyroid hormone. So at the top of this image, you will see the hypothalamus, which is a part of the brain itself. Connected to the hypothalamus is the anterior and posterior pituitary gland. But for the function of thyroid hormone release, the important portion of the pituitary gland is the anterior pituitary gland. So, let us understand how this feedback cycle or loop works. So, the hypothalamus will continuously sample the blood of the patient. So, if the hypothalamus understands or detects that the patient's blood has low levels of thyroid hormone in the form of T3 or T4, and if the patient is continuously exposed to an environment that is cold, then the hypothalamus will start to release thyrotropin releasing hormone, which goes into the anterior pituitary gland, and that stimulates the thyrotropin cells of the anterior pituitary gland to release thyroid stimulating hormone. So let's recap that. The hypothalamus will release thyrotropin releasing hormone, which goes into the portal circulation and goes into the anterior pituitary gland. The anterior pituitary gland will respond to thyrotropin releasing hormone by secreting thyroid stimulating hormone, which is also known as thyrotropin. This thyrotropin that comes from the pituitary gland will then go into the bloodstream, where it will find its way through the circulation into the thyroid gland. So understand that the hypothalamus and the pituitary gland are found in the brain at the base of the skull. But the thyroid gland is found at the neck. So this communication between the pituitary gland and the thyroid gland occurs by way of the bloodstream. So this is an endocrine communication. So in response to thyroid stimulating hormone, the thyroid gland will ramp up its synthesis of thyroid hormone as well as its resorption of colloid, and in response to thyroid stimulating hormone, it will release thyroxine, which is T4, or smaller quantities of T3, triiodothyronine, the two forms of thyroid hormone, into the circulation. So, also in response to thyroid stimulating hormone or thyrotropin, the thyroid gland will increase its uptake of iodine so that it can incorporate this iodine into thyroid hormone. It will also increase in size, a process that we call hypertrophy, and at the same time, it will increase its secretion. So the end hormones, which are thyroxine and triiodothyronine, will then be utilized by the different cells of the body because they are now present in the bloodstream. So these thyroid hormones will then increase the metabolism of peripheral cells. But at the same time, if you can remember, the hypothalamus secreted thyrotropin releasing hormone because of one stimulus, and that is a decrease in the levels of free thyroid hormone. So after the thyroid has already released the thyroid hormone due to thyroid stimulating hormone, that thyroid hormone will then find its way by circulation of the blood back to the hypothalamus, and then the hypothalamus will detect that there has been an increase in thyroid hormone, and therefore it will decrease its release of thyrotropin releasing hormone, and therefore this hypothalamic pituitary thyroid axis, HPT axis, will then slow down because you already have negative feedback. So remember that negative feedback means that the stimulation of the axis slows down whenever the product has already been released. So in that example, negative feedback is demonstrated. Let's now go into thyroid hormone biosynthesis. There are 7 steps to the formation of active thyroid hormone. So let's just run down the 7 steps. The first is uptake, next is peroxidation, organification, coupling, proteolysis, secretion, and peripheral deiodination. So let's now focus our attention on this image on the right. So the uptake is performed by the sodium iodide symporter, or NIS, which is manifested here as the orange circle. So the thyroid follicular cell will continuously take up sodium and iodide from the bloodstream, and through the action of the symporter, the sodium and the iodide will then find their way inside the thyroid follicular cell. The next step, remember that here the form of iodine is iodide, which means that it is an anion with an extra electron. Okay, so the next step is this iodide inside the follicular cell will then find its way to the opposite side of the cell, which is the side facing the colloid. So through the action of the transporter pendrin, this iodide will find its way into the colloid. Okay, so once it is already in the colloid, the next step will be peroxidation. So in peroxidation, the enzyme thyroid peroxidase, which is shown here as the green diamond, will take up the iodide and utilize hydrogen peroxide, which is in the colloid, to oxidize the iodide for it to release its extra electron and convert it into elemental iodine. So elemental iodine has no extra electron. Because of that, it becomes extremely reactive. So the end product of peroxidation is elemental iodine, which is reactive to a lot of proteins. One of these proteins are the thyroglobulins. Okay, so the thyroglobulin is actually a very long protein composed of lots of tyrosine amino acids. Okay, so if you will recall, which I will show later, tyrosine contains as its R group carbon and then phenol. So in the hydroxyl group of that phenol residue, iodine will bind itself. And here, because iodine is an inorganic substance, once it binds to the tyrosine residue, which is an amino acid, it has become functionally organified. So that step, the binding of elemental iodine to tyrosine, is what we call organification or iodination. Okay, so if you will observe, the purple circles marked Tg and YYY is actually the thyroglobulin molecule, Tg. And on its periphery are tyrosine residues, shorthanded as the letter Y. If you will look closely, the iodine will then be incorporated into the tyrosine, which is Y, forming monoiodotyrosine or MIT. Okay? The next step would be to couple these iodinated tyrosine residues. So if you will see in the third purple circle, some of the MIT monoiodotyrosine fuses with diiodotyrosine, which means that tyrosine molecule has two iodine residues. So the MIT monoiodotyrosine and the DIT diiodotyrosine are still part of the thyroglobulin molecule. They will then fuse together. So you have one iodine in MIT and two iodine residues in DIT. If they fuse together, you will have a total of 3 iodine residues. And that will be the origin of T3, which is triiodothyronine. If two molecules of diiodotyrosine will combine, you will have a total of 4 iodine residues, and that will form T4. So the combination of MIT to DIT will form T3, and the combination of DIT with another molecule of DIT will form T4. That process of combination is called coupling. Okay? So, after peroxidation, organification, and coupling, you will have thyroglobulin residues which contain the parent hormone of T4 and T3. Remember that the thyroid follicular cell, in response to thyroid stimulating hormone, will take up these thyroglobulins so that they can process the thyroglobulin molecule to generate the end hormone, and in effect, in response to TSH, release the end hormone. So the next step would be to take up these thyroglobulin residues and hydrolyze the thyroglobulin residues. So basically, the thyroid follicular cell will digest the thyroglobulin molecule, and after digesting it, proteolysing it, release the end hormone, which are T3 and T4. But if you will observe the thyroglobulin molecule, not all of it will have T3 and T4 at the end of coupling. So, some of it will still have MIT and DIT, and these non-T3, non-T4 tyrosines will then be recycled by the thyroid follicular cell via the action of iodotyrosine deiodinase, which will liberate again the iodide molecule, which will then go into the colloid again. Okay, so after proteolysis, the end hormones will be secreted into the circulation, and it will then circulate with the blood to the different tissues of the body. But you have the ultimate step, which is the conversion of T4 into T3. Remember that at this point, T4, tetraiodothyronine, has 4 iodine residues. T4 tetraiodothyronine is also called thyroxine. So, the pattern of secretion of the thyroid gland is it will secrete a lot of T4 and few T3. But the active hormone, which is utilized by the peripheral cells as a transcription factor, the final thyroid hormone and the more potent thyroid hormone is T3. So here in the blood, you have lots of T4, which are less active, and less of T3, which is more active. So for the cells to be able to use the thyroid hormone that is in the blood, it will have to convert the T4 thyroxine into T3, which is triiodothyronine. So there is this final step which occurs in the blood vessel and in the peripheral tissues, which is called peripheral deiodination, where you remove an iodine molecule from T4 and convert it into T3. So let's just recap the 7 steps in thyroid hormone biosynthesis: uptake via NIS, peroxidation, which occurs in the colloid via thyroid peroxidase, where iodide is converted into elemental iodine, organification, where the elemental iodine, which is very reactive, is taken up by the thyroglobulin molecule and added into its tyrosine residues. Coupling, where the iodinated tyrosine residues pair up with one another to form T3 and T4. Proteolysis is the taking up of the thyroid follicular cell of the iodinated thyroglobulin, which contains the nascent or the newly formed T4 and T3. And then there is proteolysis and hydrolysis of those to liberate the free T3 and T4, which is then secreted into the bloodstream. And in the bloodstream, the peripheral cells will then take up the T4 and convert it into T3 via peripheral deiodination, or utilize the small quantities of free T3 right away. So here is the process that I was describing a while ago. At the top portion of the panel, you will see that at the start, you will have iodide, which has a free electron. And via oxidation, with the help of hydrogen peroxide, you will form elemental iodine, which will then be taken up by the tyrosine that is bound to thyroglobulin to form monoiodotyrosine, or if two iodine molecules are taken up, diiodotyrosine. The diiodotyrosine will combine with another diiodotyrosine in the process known as coupling to form T4 tetraiodothyronine, also known as thyroxine. The diiodothyronine, pwede din another combination, will or can fuse up with monoiodotyrosine to form triiodothyronine or T3, which is the active and the potent hormone. Tetraiodothyronine or thyroxine can be thought of as a prohormone, which needs to be converted into the active hormone triiodothyronine via peripheral deiodination. So now let's see the functions of thyroid hormone. Number 1, it acts as a transcription factor. And because it is a hormone that acts via the nucleus, the end products of which are proteins, which will then produce the effects of thyroid hormone, we understand that its onset of effect is within hours, but the duration is within days because you are utilizing the central dogma. In most tissues of the body, thyroid hormone increases oxygen consumption and heat production because it speeds up metabolism, which ultimately requires ATP and therefore is generated in the presence of oxygen. And so, the oxygen consumption and heat production increases. It does this by increasing the number and activity of mitochondria, and it stimulates the activity of the sodium-potassium ATPase, which will pump out of the cell sodium and pump inside the cell potassium, which is against the concentration gradient and therefore utilizes adenosine triphosphate, which is readily available because you have increased the number and activity of mitochondria. Next, the third bullet, it causes increased thermogenesis and sweating. Remember that when I talked about the hypothalamic pituitary thyroid axis, one of the stimulus is exposure of the organism or the patient to a cold environment. And so, via the action of thyroid hormone, that organism or patient will be able to adapt to the cold environment because of increased thermogenesis and sweating. This is also the reason why we see that most patients who live in colder environments, example, if they are in the mountains, will have higher prevalence of goiter because their thyroid glands will have to hypertrophy to adapt to the cold environment via thermogenesis. Thyroid hormone, because it will speed up the metabolism and the oxygen and nutrient requirement are increased of the peripheral cells, it will then lead to widespread vasodilation so that these peripheral cells will be able to contact lots of blood, and therefore the requirement for blood flow of the peripheral cells increases. So the response of the cardiovascular system would be peripheral vasodilation, and to maintain blood flow in the dilated blood vessels and to maintain the blood pressure, the response of the heart would be increased cardiac output. So patients with hyperthyroidism via this mechanism also has increased risk of developing high output heart failure. So their hearts will dilate pathologically, but the origin of that is to produce increased cardiac output because of an increased blood flow demand of the periphery. Because thyroid hormone speeds up metabolism, it will increase the utilization of carbohydrates, glucose, fats in the form of fatty acids, and amino acids in the peripheral cells, because at the end of the day, these substrates will be broken down to provide energy. And as these substrates are broken down to provide energy, it will then be needing lots of coenzymes and cofactors. The turnover for these coenzymes and cofactors will be very high so that there is an increased demand for vitamins. Thyroid hormone is essential for normal growth and development, especially the fetus inside the womb, okay, and early childhood. So it is also at this time embryonic and fetal development and early childhood that the requirement for thyroid hormone is crucial. And if you do not provide thyroid hormone at this time, then the risk for abnormal development of the nervous system is increased. Okay. Next, you have the next effect of thyroid hormone is central nervous system excitation. It keeps the central nervous system alert and running. And so, an extension of that is if our patient has hyperthyroidism, that patient will manifest with agitation and anxiety, a term that we call hypercerebration. Hindi nila kayang i-turn off ang kanilang thinking, especially at night. So you will see here in this image the mechanism of action of thyroid hormone. So, appreciate that at the top of this image in the cell membrane, T4 and T3 can eventually enter the cytoplasm. And that is because T4 and T3 are lipid-soluble hormones, even if the nature of the hormone is a peptide. Okay, so T4 can enter the cytoplasm, but eventually it will have to be converted to the active hormone, which is T3. T3 will then enter the nucleus through small holes in the nuclear membrane. Here, manifested as the yellow oval and the teal square are coupling of different receptors. So these receptors, the retinoid X receptor, which is activated by vitamin A, is attached with thyroid hormone receptor, which is activated by thyroid hormone. What this shows is that these two receptors are co-receptors, which means that for thyroid hormone to exert its effect, the retinoid X receptor must be activated also by binding of vitamin A. And so, to produce thyroid effects, you need ample amounts of vitamin A. So, the thyroid hormone receptor, once it is bound by T3, will then facilitate the transcription of genes that are responsive to thyroid hormone. And this segment of the gene is called the thyroid hormone response element. So the products of transcription are mRNA. And then mRNA, like in the central dogma, will leave the nucleus and enter the cytoplasm, where it will be utilized by the protein synthesis machinery, tRNA, and the different ribosomes to form new proteins. And it is, at the end of the day, these proteins that produce the effect of our original signal, which is T3. So, these proteins have effects on other organ systems, effects on growth, central nervous system development, on the action of the heart and the blood vessels. It increases the cardiac output, tissue blood flow, heart rate, inotropy, and the rate of respiration. Because if you will remember the effects of thyroid hormone, it increases metabolism and the requirement for oxygen. And so, to provide that, thyroid hormone will also increase the rate of ventilation and how deep the breathing occurs to supply oxygen. For metabolism, its protein products include the components of the mitochondria, the sodium-potassium pump, enzymes that utilize oxygen for the production of energy, enzymes or proteins, for glucose absorption, enzymes for gluconeogenesis, glycogenolysis, lipolysis, and protein synthesis. So if you understand, gluconeogenesis is sped up by thyroid hormone. That is a pathway that breaks down proteins and amino acids. But at the same time, thyroid hormone will also speed up protein synthesis. So in this point, both of these metabolic pathways are sped up, and that becomes a futile cycle. These pathways are ongoing, but they are not achieving anything. So, what we generally call this one is increased protein turnover. Okay, there is increased deposition of protein, but at the same time, there is increased catabolism of the protein. And overall, the action of thyroid hormone increases the basal metabolic rate. So now let's go to some common thyroid diseases. First is Graves' disease. So this is the most common form of hyperthyroidism. So when we use the term hyperthyroidism, that means that there is excessive effect of thyroid hormone, and we can measure an increase in thyroid hormone in the blood. So the mechanism for the disease, which is Graves' disease, is there is autoimmune agonism of the TSH or the thyrotropin receptor by thyroid stimulating immunoglobulin. So what does that mean? The plasma cells of the body continuously create an immunoglobulin or antibody which mimics the action of TSH, which is originally produced by the pituitary gland. So these antibodies which mimic TSH also bind to the thyroid gland and stimulate the activity of the thyroid follicular cell. So at the end of the day, this is an escape of the negative feedback mechanism. So the end effect is increased release of thyroid hormone. So the symptoms are natural extensions of the effects of thyroid hormone, which include increased metabolic rate, heat intolerance, and sweating. These patients, because of the increased metabolic rate and thermogenesis, they are creating lots of heat. Then, if you place them in a hot environment, they cannot tolerate it. Next is weight loss despite increased appetite. So, the basal metabolic rate is increased, and so the use of the substrates, proteins, lipids, and carbohydrates are increased. And so, the patient will naturally increase also his or her intake of food to supply that increased catabolism of those food products. Yet, even if the patient takes in a lot of food, because the metabolic rate is just so high, the patient will still experience weight loss despite the increased appetite. There are also palpitations and tachycardia, nervousness and emotional lability, muscle weakness because the proteins of the muscles are continuously broken down to support gluconeogenesis, and tiredness and insomnia. So the insomnia, as I have alluded to a while ago, can be due to hypercerebration, the inability of the patient to slow down his or her thoughts, or the insomnia can be due to palpitations, which make it difficult for the patient to sleep. So here is the theoretical model of intrathyroidal Graves' disease. Okay, so this is the mechanism. So just focus your attention on the B cell or the B lymphocyte, which is a plasma cell, which develops into a plasma cell that secretes antibodies. So the abnormal antibodies that are secreted by the B cell are the thyroid stimulating antibodies, the orange Ys. Okay, so these antibodies will then bind to the thyrotropin receptor on the follicular cell. So the follicular cells here are the epithelial cells, and the white portion that is against the side where the thyrotropin receptor is located is the colloid. So by binding of the TSI or thyroid stimulating immunoglobulin, there is increased levels of cyclic AMP, which will then activate the thyroid follicular cell, which will lead to the thyroid gland taking up lots of colloid and outputting into the circulation lots of thyroid hormone. But as I have discussed a while ago, on the axis, the hypothalamic pituitary thyroid axis, thyroid stimulating hormone TSH and its counterpart in Graves' disease, which is TSI, will also stimulate the proliferation and the growth of thyroid follicular cells. And so a dreaded effect of lots of TSI will be the complication of abnormal or dysregulated growth of thyroid cells. Eventually, the hypertrophy and the hyperplasia will lead to abnormal growth of these cells. From normal, they become dysplastic and they will show cancer-like behavior. And so patients who have diseases that lead to increased division of the thyroid cells will eventually have a higher risk of having thyroid cancer. So for hypothyroidism, the most common cause is Hashimoto's thyroiditis. So in Hashimoto's thyroiditis, there is autoimmune attack of the thyroid gland, and this attack from the immune system on the thyroid gland leads to destruction of the thyroid gland and its thyroid follicular cells. So initially, once the inflammation of the thyroid gland is severe, there will be leaking of the thyroid hormone into the circulation. So early on in the disease, the patient will have hyperthyroidism, and then later on, as the thyroid cell dies and as it is replaced by scar tissue, there will be decreased synthesis of thyroid hormone and eventually absence of thyroid hormone. So later on in the disease and throughout the life of that individual, he or she will manifest with hypothyroidism. So the symptoms are opposite those of hyperthyroidism. And here, we're expecting that all of the effects of thyroid hormone will be lost. Remember that thyroid hormone is important for the turnover of protein. So in patients with hypothyroidism, there is what we call non-pitting edema. So their foot especially and eventually the rest of their body will accumulate undigestible protein. So beneath their skin and beneath in the extracellular space, instead of fluid being there will be protein that is not degraded, that is not subjected to turnover. And so they will look edematous, and if you press the skin, it will not depress because it will not form a pit, because that is gel, that is proteoglycan that has not been degraded. So there will be non-pitting edema. There is also called mixed edema, where there is very low thyroid hormone in the adult, that is a critical value. Very low thyroid hormone, so that that individual will not be able to provide enough blood pressure. So patients with mixed edema will usually have shock, very low blood pressure, because there is no thyroid hormone to support the activity of the cardiovascular system. In children, because thyroid hormone is essential for in utero and childhood development of the nervous system, there is usually cretinism. So in cretinism, we see that these children are dwarfed. Ibig sabihin, they did not grow normally in size, in stature, compared to their normal counterparts. And at the same time, they will have irreversible mental retardation. So, this irreversible mental retardation means that for the rest of the life of that child, he or she will not be able to contribute to society and will not live normally because of the mental retardation. So, it is important that we understand that iodine is the source of thyroid hormone because it is the one that is incorporated to form thyroid hormone. And in countries where there is poor iodine supplementation of the salt and food, the populace will not be able to take up adequate iodine to make thyroid hormone. And so, the rates of cretinism and mental retardation in these countries is higher. So, what the Philippines did was to adopt a law that mandates that salt be the salt that is available for the population be iodinated. And it is good to note that after the passage of this law, the rates of cretinism and mental retardation has been significantly reduced. So let's now go into how we treat disorders of the thyroid gland. There are many different disorders of the thyroid gland, and what we have just shown are common examples of hyperthyroidism and hypothyroidism. First is thyroid hormone therapy. When do we give thyroid hormone therapy? Hormone replacement in hypothyroidism and TSH suppression in patients with thyroid cancer. So, when do we give T4 and T3? When do we give thyroxine and triiodothyronine? When we want to replace low levels of thyroid hormone in patients who are not able to synthesize thyroid hormone. So that is in hypothyroidism because their thyroid glands are unable to synthesize thyroid hormone, then we should be providing the thyroid hormone exogenously. We can also provide thyroid hormone to utilize negative feedback. So in patients who have received surgery for their thyroid gland because their thyroid gland has thyroid cancer, so we remove the thyroid gland, and after that we give them thyroid hormone. So the goal of that is to provide thyroid hormone which the patient is unable to synthesize because of the removal of the thyroid gland, but at the same time high levels of thyroid hormone that we are providing for that patient will provide negative feedback to the hypothalamus and the pituitary gland. Without activation of the pituitary gland, it will not synthesize thyroid stimulating hormone, which is an important growth factor for thyroid follicular cells. And to add to that, thyroid cancer cells will proliferate and survive if they have TSH. So your goal here would be to suppress the release of TSH by providing thyroid hormone, which will stimulate negative feedback. So What thyroid hormone preparations do we give? We can give an analog of T4, which is levothyroxine, and an analog of T3, which is liothyronine. Levothyroxine has 80% absorption, which means if you give 100 micrograms, 80 micrograms will be available to the systemic circulation if it is given by mouth. It peaks at 4 hours and has a half-life of 7 days. It is available in both oral and intravenous. So the principle here is if you give T4, you will have slower onset of effect but prolonged effect. The half-life is 7 days. And the goal here is to provide T4, which is converted peripherally by the cells into the active T3. Liothyronine, on the other hand, has 100% absorption. It peaks at 4 hours and has a half-life of 3/4 of a day. So that means that we are going to provide liothyronine if we need rapid thyroid activity, such as when the patient has mixed edema coma, where the blood pressure is very low and the patient will die without rapid thyroid hormone activity. And we can also do this if we need to prep the patient for with thyroid cancer for radiotherapy. Leotrix is a combination of both T4 and T3 in a 4:1 ratio, and this is prepared from desiccated or dried up thyroid gland, and this is packaged in the form of tablets. So here again is our negative feedback mechanism. A while ago, I told you that patients who have suffered from cancer and who had their thyroid glands removed or irradiated, which means we applied external beam radiation to kill off the thyroid cells, these patients will need high dose, supranormal doses of T3 and T4. And your goal there is to provide the end hormone T3 and T4 so that it stimulates negative feedback on the hypothalamus and the pituitary gland. Negative feedback on the hypothalamus will decrease secretion of thyrotropin releasing hormone and therefore will not stimulate the anterior pituitary gland to secrete TSH, which is needed by cancer cells, thyroid cancer cells, for growth. The negative feedback that occurs on the anterior pituitary gland will also prevent the release of thyrotropin or TSH, so that again, the thyroid follicular cells which have become cancerous will not have growth factor which will help them grow. So here, the hormone that you are giving is an anti-cancer medication. Next is thyroid hormone replacement. If you have the disease hypothyroidism, then you need to provide thyroid hormone because that patient's thyroid gland is unable to synthesize thyroid hormone. So the drug of choice for thyroid hormone replacement is thyroxine because it has more stable blood levels because of its long duration of activity and consistent potency. The rate limiting step there for the activity of the thyroid hormone replacement is the peripheral deiodination of T4 into T3. So, remember that in patients who have hypothyroidism, there is no negative feedback on the anterior pituitary gland. And therefore, if you take measurements of TSH in these patients, you will see that the TSH will be elevated because the pituitary gland will want to stimulate the thyroid gland to synthesize T4. But because the thyroid gland is diseased, even if there is lots of TSH, you have low T4. So if you have hypothyroidism, the picture in the blood will be low T4 and T3 and high TSH. So if you are already providing thyroid hormone replacement to this patient, you can utilize TSH to guide you if you are giving enough thyroid hormone or T4. So early on, without your thyroid hormone replacement, the TSH will be high. But as you continue to provide the T4 and the T3, the TSH will continue also to drop because negative feedback is re-established. And so your goal is to normalize the serum TSH and also relieve the hypothyroid symptoms. So, in pregnant women who, aside from the requirements of the mother, will have to provide the thyroid hormone requirements for the developing embryo and fetus, there is a need to increase the T4 dose because you have in pregnancy high levels of thyroid binding globulin. So this protein, which is thyroid binding globulin, will sequester the T4 and the T3 in the plasma. And so the levels of free T4 and T3 will drop if you have high levels of the binding globulin. Because pregnant women have higher levels of thyroid binding globulin, you need to increase their intake of thyroid hormone. Next, the placenta, which is the communication of the mother's circulation with the baby's circulation, expresses type 3 deiodinase. So what does that mean? If at baseline, you are giving a hypothyroid mother T4, if that mother becomes pregnant and there is already the presence of the placenta, you need to increase the thyroid hormone of that mother because the thyroid hormone that is in the blood of the mother will not be able to reach the fetus because it is destroyed by the placenta. And so to provide thyroid hormone to the fetus who has underdeveloped thyroid gland, you need to increase the dose of T4. And to add to that, T4 that is in the blood of the mother has a difficult time reaching the blood of the fetus. There is a poor transplacental passage. So in mixed edema coma, this is a severe form of long-standing hypothyroidism. So you need to provide a loading dose of T4. So initially, you provide T3 to provide rapid activity of thyroid hormone, and then instead of just giving the normal requirement of T4, you provide a loading dose higher than the normal dose before you taper off to lower T4 doses. So, in congenital hypothyroidism, you initiate T4 replacement at the first 2 weeks of life to achieve normal development. So, in babies who at birth have poor functioning thyroid gland, you need to start providing these babies with hormone replacement at the first 2 weeks. Why? Because at the initial 2 weeks, the baby is still taking up the thyroid that is given off by the thyroid hormone that is given off by the mother. But as the baby has been born already and there is no blood to blood communication with the mother, the levels of thyroid hormone of the baby will continuously go down. So if you are not providing thyroid hormone replacement for the baby after 2 weeks, who now has low levels of T4 in his or her blood, then you will not be able to support brain development. Lastly, in cancer, where the patient will have thyroid cancer, where the patient will have surgery of the thyroid gland, removal of it, radiotherapy, you need to provide chronic T4 replacement, again, to suppress TSH and slow down the cancer cells from growing if meron mang naiwan. Next, you have thyroid inhibitors. Next, we have the thyroid inhibitors. So, there are instances by which we have to control the overactive thyroid gland. So, we use thyroid inhibitors to do this. So, we have many types of thyroid inhibitors. The first are antithyroid drugs, which interfere directly with hormone synthesis. Next, you have ionic inhibitors, which block iodide transport. For this, remember that the sodium iodide symporter takes up iodine and sodium for it to be able to enter the follicular cell. So it is at that point that ionic inhibitors work. Next, you have high iodine concentrations, and this utilizes the Wolff-Chaikoff effect. So the high iodine concentrations decrease thyroid hormone synthesis and release. And lastly, radioactive iodine will be taken up by the thyroid gland, and once they are activated to release radiation, it damages the thyroid gland. So here we have antithyroid drugs. The most common that we see in the market are propylthiouracil, which is shorthanded as PTU. Next, you have the newer agents, methimazole and carbimazole. So, the family of these drugs are the thiouracilins, which are thioamines. So, the prototype or the first agent that was made is propylthiouracil. So, how does it work? Because it is an inhibitor of thyroid peroxidase, it will inhibit the incorporation of iodine into thyrosyl residues. So for this one, remember how thyroid hormone is synthesized. The iodine that has been acted upon by thyroid peroxidase should be incorporated into tyrosine, and that tyrosine that is present in the thyroglobulin will then be taken up by the thyroid follicular cell proteolysis to secrete T3 and T4. But if you prevent the incorporation of iodine into the tyrosyl residues, you won't be able to synthesize T3 and T4. It also prevents the coupling of iodotyrosyl into iodothyronines. Remember that MIT together with DIT will form T3, and two molecules of DIT will form T4, and that combination is what we call coupling. These antithyroid drugs will prevent that one, so you will not have T3 and T4, but you only have DIT or MIT. It inhibits thyroid peroxidase, which will then prevent the conversion of iodide, which has an extra electron, to the active and reactive iodine molecule. So without this conversion into the iodine molecule, you will not be able to incorporate the iodine into the thyroglobulin, preventing organification. Lastly, as the inhibition of the thyroid hormone synthesis in the colloid um, is ongoing, the older stores of the thyroid hormone will be utilized first. But eventually, all of the thyroid hormone that has been synthesized will be depleted. And therefore, when that time comes, the thyroid hormone stores, because of the action of the antithyroid drugs, will be absolutely depleted. And that will prevent further activity of the thyroid gland. So only for propylthiouracil, there will be partial inhibition of peripheral deiodinase. So what does that mean? That final step, which converts the prohormone T4 into the active hormone T3, will eventually be inhibited by propylthiouracil. So the other drugs, methimazole and carbimazole, will work only on the thyroid gland, but propylthiouracil has an additional effect of working in the blood vessel, preventing the conversion of T4 to T3. So we use this in severe hyperthyroidism and in thyroid storm. In thyroid storm, there is an extremely elevated level of free T4 and T3. So, the adverse reaction, which is commonly observed in propylthiouracil use, is agranulocytosis. What this means is that the levels of neutrophils will go down. So, when the levels of neutrophils go down, then that patient is at high risk of getting severe infection, and that patient is at high risk of developing sepsis. So the uses of these drugs are in Graves' disease. This is the definitive treatment to control the disorder while anticipating spontaneous remission. So in minority of patients with Graves' disease, remember that the mechanism is there is an abnormal antibody that stimulates thyrotropin receptor. So in a subset of these patients, there will be reversal of the Graves' disease. And so, while waiting for that remission, we can cover the hyperactive thyroid gland of that patient with antithyroid drugs. So another use is in conjunction with radioactive iodine. Eventually, some patients will need to have their thyroid glands ablated or destroyed using radiation to prevent further secretion. Why? Because it is much more dependable to destroy the hyperactive thyroid gland and just replace the needed thyroid hormone than suppress the thyroid gland and using medication suppress the hyperthyroidism. So again, it is preferred because it is preferred to have the thyroid gland removed and just replace the thyroid hormone because you can predict the effects. But if you leave the thyroid gland there and the thyroid gland is hyperactive, you will have much more difficulty controlling the hyperthyroidism. So if the contemplated procedure to remove the thyroid gland is surgery, which in many ways has lesser side effects in the hands of an experienced surgeon compared to radioactive iodine, if your definitive treatment is to remove the thyroid gland, then you need to control the hyperthyroidism by depleting the thyroid colloid, so that once the surgeon will slice the thyroid gland, there won't be spill over into the blood. There won't be thyroid storm. So that is also one use of these antithyroid medications. So again, I'd like to emphasize the difference between hyperthyroidism, which is measured levels in the blood of thyroid hormone, high measurement in the blood, and thyrotoxicosis, which is in essence the symptoms that are produced by excessive thyroid hormone. So in pregnancy, PTU and methimazole are equally safe, but for our purpose, in the board exam, disregarding the evidence that we have, PTU is considered a better option for pregnant women because it will not cross the placenta and it will not harm the fetus. But right now, what we see in evidence is that they are equally safe. However, PTU can cause liver failure, and therefore these patients are at higher risk of developing liver complications with the use of PTU. So adjuvants, ibig sabihin add-on therapy to control the sympathetic hyperactivity in patients with hyperthyroidism include beta blockers and calcium channel blockers. So patients with hyperthyroidism will usually complain of palpitations, and if you will understand that the mechanism of action of thyroid hormone is to upregulate the levels of adrenergic receptors, by blocking these adrenergic receptors, we'll also see a blockade of the natural effect of thyroid hormone, which in hyperthyroidism is exaggerated. So, to improve the remission rate of Graves' disease, we can use rituximab. Why? Rituximab prevents the development of plasma cells, so that if we don't have active plasma cells, there will be less cells that will produce the pathologic entity that thyroid stimulating immunoglobulin or antibody. So next, you have ionic inhibitors. Examples are thiocyanate, perchlorate, and fluoroborate. So these are substances that interfere with the concentration of iodide by the thyroid gland. These anions, thiocyanate, perchlorate, and fluoroborate, resemble iodide and therefore are competitive inhibitors at the sodium iodide symporter. Thiocyanate is qualitatively different. It is not concentrated by the thyroid gland in large amounts, but it also inhibits organification. So, what does that mean? Thiocyanate blocks the uptake of iodide, but the thyroid gland will not store the thiocyanate. Perchlorate blocks iodide uptake by competition at the NIS. So similar in mechanism, but we try not to use perchlorate because it can prevent the development of stem cells in the bone marrow, leading to fatal aplastic anemia, where the patient will have low levels of hemoglobin, low levels of white blood cells, and therefore prone to infection, and low levels of platelet, prone to bleeding, fatal bleeding. Lithium blocks T4 and T3 secretion and leads to overt hypothyroidism in manic patients. So in patients who have the psychiatric disorder of bipolar disorder, usually they will take in lithium, And in these patients, we need to observe their thyroid hormone status because they will usually have hypothyroidism because of the lithium. And lastly, you have iodide. So iodide is present in Lugol solution, which is sodium iodide and elemental iodine, and KISS, potassium iodide saturated solution. So iodide was the oldest remedy for disorders of the thyroid gland, and it utilizes the Wolff-Chaikoff effect. So the excess iodide will limit its own uptake, and therefore it will lead to a transient inhibition of the synthesis of thyroid hormones. So this also leads to an inhibition of thyroid hormone release. So you have here the response to iodide in hyperthyroidism. So you have striking and rapid effects of iodide in hyperthyroidism. So you will have an extensive acute Wolff-Chaikoff effect, and then later on an escape. So what does that mean? If your patient has hyperactive thyroid gland, which means that that patient is very avid in taking up iodine and synthesizing thyroid hormone from iodine, once we utilize the Wolff-Chaikoff effect and give the patient high levels of iodine, initially that patient will stop synthesizing thyroid hormone. But later on, the hyperactive thyroid gland keeps up and then utilizes the excessive iodine that you are giving that patient to synthesize more and more thyroid gland, thyroid hormone. So that will lead to later on excessive hyperthyroidism. So this is what yung escape na yun is what we call the Jod-Basedow effect. Okay? So next you have atrophy and decreased vascularity of the thyroid gland. And this is what we are trying to achieve in patients who are to undergo thyroid surgery. We want to decrease the vascularity of their thyroid gland by giving them iodine so that once the surgeon will cut the thyroid gland, it will not be bloody. So the use here is pre-operative preparation for thyroidectomy or removal of the thyroid gland, and management of thyrotoxic crisis with antithyroid drugs and propranolol. So if the thyroid activity is just really excessive, on top of the antithyroid drugs and propranolol to control the physiologic effects of thyroid hormone, you can utilize the Wolff-Chaikoff effect to decrease acute synthesis of thyroid hormone. So here I just added this slide to help you appreciate that there are drugs that are not utilized for its effects on the thyroid gland, but on other systems of the body, yet contain lots of iodine. And so by giving these drugs to your patients who are at the verge of developing hyperthyroidism, you may push them into hyperthyroidism, or you may push them into hypothyroidism by the Wolff-Chaikoff effect. So for example, amiodarone is 35% by weight iodine. So if you give patients amiodarone for the treatment of their arrhythmias, then you are indirectly providing them with iodide that their thyroid glands can use to synthesize thyroid hormone. And later on, you might observe that these patients who are taking amiodarone have hyperthyroidism. Other drugs are iodoquinol, ecothiopate, iodochlorhydroxyquine. So this is used in malaria. Povidone iodine, which is utilized uh, as an antiseptic in the skin, but large effects of this drug may be observed in patients who have oral surgery, okay, and in seaweed and kelp. So that's it for our lecture on the thyroid gland. So thank you for listening to this lecture on thyroid pharmacology.